and in person. So I'm one of the pediatric anesthesiologists, and I am the assistant director for med student education within the anesthesiology department. And then Dr. Matt Wixon is joining us virtually. And so he is an adult anesthesiologist, and he is the director for med student education for anesthesiology, as well as being the associate chair for diversity, equity, and inclusivity. And we want to thank the leadership of the Medical Students for Disability Health and Advocacy Group for inviting us to talk about this really important topic. And we're excited to share our clinical experience during National Disability Awareness Month. And then we also want to thank Dr. Lisa Meeks, who is an extensively published expert in this topic, who assisted us, as well as Ms. J.T. Sangsland, who I think I saw maybe in the virtual audience, who is a learning and accessibility manager at the University of Michigan Medical School, for her help and expertise on the talk and in real life. How do you advance? Oh, just there. Sorry, technical issues, everybody. Okay. So neither Matt nor I have any disclosures. And okay, so this is going to feel kind of formal, but please feel free to interrupt in real life or on the chat if you have any questions that come up. And when we initially gave this a version of this talk, it was to the anesthesiology department. And so we started by sharing our departmental DEI statement, because we felt like that was like a very important place to start to kind of have everybody on the same page. And so I'll just share that with you, with everyone now. The Department of Anesthesiology aspires to create collaborative community that is welcoming and supportive of diverse individuals. Through reflection, education, advocacy, and research, we aim to create curious leaders who will be representative of our global populations and colleagues. We believe that broad diversity enhances excellence, our ultimate pursuit. And we have found that this is a topic that can be really challenging within the clinical realm and can bring up a lot of really strong feelings. And so we just kind of wanted to start with this grounding idea. These are the things that we're going to talk about, but again, it's, doesn't have to be formal if people have questions. And so as we get started, I want you to start thinking about the word disability, what that means to you. What image does that bring to your mind? There's no right answer. This is going to mean different things for different people, but especially for some of our colleagues in the clinical space who haven't thought about this maybe as much as you all have. This is something we just want to challenge people to think about. So some background about why we feel like this is an important topic to share with our department and with people more broadly. As of 2015, there were about 1,500 or 2.7% of medical students who had disabilities that received accommodations in United States MD granting schools. There was a follow-up survey in 2019 where that number had already increased to 2,600, which is a really big increase in a pretty short period of time. And while the proportion is increasing, it still lags behind the percentage of people with disabilities in other secondary educational settings. So there's 11.1% of students in undergraduate and 7.6% in graduate schools. And it definitely lags behind the 1 in 4 United States adults who are estimated to have a disability that impacts major life events. And when we think about disability, I think most people envision visible disabilities or apparent disabilities, such as disabilities impacting mobility. But you can see from the work by Meeks and Herzer in 2016, within the proportion of students with disabilities in US MD granting programs, the largest proportion were non-apparent or invisible. And this preponderance of invisible or non-apparent disability applies to non-medical students as well. It's estimated that 96% of disability in United States adults are invisible or non-apparent. And you can also see when you look at this proportion of students with disability that 20% of the disabilities are psychological in nature. And so it's easy to imagine that this number might actually be even, oops, sorry, we went out of control. Sorry, everybody. Okay. So it's easy to imagine that given like the stigmatization of mental health, that number might actually be even higher, right? So there was a study by Rotenstein and colleagues in 2016 that showed that an estimated 27.2% of medical students were depressed and 11.1% experienced suicidal ideation. And given the trends in burnout that we're all like witnessing and experiencing, it seems likely that this number probably hasn't gone down since 2016. And so I wonder, like, what do you all think of that? Are these numbers surprising? Are they higher than you thought, lower than you thought? Does anybody have any thoughts or reactions to that? It's okay if you don't.
I personally feel like it's not that surprising, just like seeing my peer, like talking to my peers and seeing like how prevalent depression on my mentally is but
Do you feel like this number is like 27.2 is like an underestimation or accurate representation? Or even outside of psychological realms, like, do you feel like the overall idea that only like 2 to 3% of medical students have a disability that impacts?
Seems low.
Yeah. I mean, it gets really tricky because some elements of this have to do with disclosure as well, right? Which we are going to talk about in a little bit. Let's see if I can advance the slides without going 15. Okay, Max has maybe helped me. Okay. All right. So this is a study that you might have seen. This was on the popular media, and it was also in a lot of medical communities on social media. And this was a qualitative study by Tara Legu and colleagues in 2018. And that's Tara Legu pictured there. And the study was done by three-way video conference. Because it was done by video conference, nobody knew that they were talking to someone who was a wheelchair user. They interviewed rural and non-rural physicians that were both primary care and subspecialty. And they used a semi-structured interview guide, and they talked about issues relating to care for people with specific disability types, as well as to assess knowledge and application of the ADA, and then general barriers to and facilitators of caring for people with disabilities. They interviewed a total of 22 physicians, and they identified a lot of barriers to caring for people with disabilities within physical and communication domains. And those things went on to create cultural and structural barriers for these patients. They also highlighted self-identified deficits in knowledge, experience, and skills of the physician. And none of that is, unfortunately, that surprising to me, at least. But what was really upsetting were the negative attitudes, outdated and ableist language that the physicians used. And they're showcased here with this quote. We've gotten to a point in society where a lot of people are wanting some form of accommodation and a lot are illegitimate. They want their pet peacock on the airplanes and whatnot, and it makes it very difficult. Or some other quotes from the study were, quote, they can create a big deal out of nothing, or quote, are an entitled population. And in the study, they even go so far as to describe strategies for dissuading or discharging them from their practice. There was a different study by Iazzoni and colleagues in 2022, and they surveyed over 700 physicians. So in case you were hoping like maybe it was just these 22 physicians that we interviewed who were like awful, these were practicing US physicians, and they found that only 41% of respondents reported that they were very confident about their ability to provide the same quality of care to people with disabilities as to those without. And maybe you'd be wondering if these are just like attitudes or biases, but maybe they didn't actually impact patient care. There's a multitude of studies that have uncovered the fact that people with disabilities experience profound healthcare disparities, including higher rates of early death, preventable chronic conditions, oral diseases. They're more likely to have severe medical complications, to experience hospitalizations than those without disabilities. People with disabilities are more likely to have unmet healthcare needs and use fewer medical services associated with preventative care. So for example, women with disabilities are less likely to have regular mammograms and more likely to have cancer detected at a later stage. And we can look at this diagram of the interconnectedness of domains that affect health status. It's pretty easy to see how having a disability could have far-reaching impacts on multiple areas, contributing to these significant disparities compared to someone without the disability. And as we reflect on these statistics, I think it's important to think about how many patients we take care of every day who have disabilities. Certainly in anesthesiology in the OR, like that's a lot of our patients are coming to the operating room for some significant reason. And to consider how might continued efforts to diversify our workforce lead to a positive impact in this area. So diversity of physicians has got well-established positive effects on patient care and access for marginalized groups. When you look at the impact of shared race or ethnicity on a variety of domains, there is study after study showing the benefit of physician-patient concordance in race or ethnicity. So there's a positive impact of shared race or ethnicity on time spent together, on medication adherence, and shared medical decision-making, wait times for treatment, cholesterol screening, patient understanding of cancer risk, patient perceptions of treatment decisions, and implicit bias from the physician. And I think this is like an area of dialogue that is out there in the mainstream. Like this isn't necessarily surprising to anybody these days. But while similar positive effects on the access and care of patients with disabilities is unstudied, it makes sense to wonder if these findings might be able to be extended, particularly when you consider the preceding studies that show barrier after barrier for patients with disabilities to receive medical care. And then even beyond the positive effects that physicians with disabilities might have on patients with disabilities, there's also evidence that close relationships between non-disabled and disabled people can change attitudes about disability. And so that could create a really positive like ripple effect throughout our patients. And then finally, I would just say that if anyone, which I wouldn't imagine in this group to be true, but if anyone is unmoved by all the previous slides about the patient care and disability, I would just suggest that having disability or not having a disability is not an unmovable characteristic of self over time, right? Like that's not a static, like this is a thing and now it's true forever. And so when you consider, the increasing number of medical students who have disability, within anesthesiology, we have an overall aging population of anesthesiologists. It's, I think reasonable to imagine that you will likely be personally or professionally impacted by this. So now that we've spent a little bit of time kind of talking about why this is an important topic, why this is something that Matt and I care about, we wanted to pivot a little bit to talking about some of the legal considerations for education of learners who have a disability. And I will also say that I am obviously not a lawyer, nor am I a disability specialist expert. And so if there are questions that are outside of my scope, I'm happy to circle back to you after finding the right answer, but that those are not my areas of expertise. So disability is defined as a mental or physical impairment. Is it working? Oh, no, we're good. Okay. That substantially limits one or more major life activities as compared with most people in the general population. And Section 504 of the Rehabilitation Act in 1973 is where it was originally stipulated that programs or activities to receive federal financial assistance may not exclude from participation, deny the benefit of, or subject to discrimination any otherwise qualified individual with a disability solely by reason of her or his disability. And this was extended to private sectors with the ADA in 1990. That brings us to accommodations. And I would say understanding accommodations in medical education is one of the most important aspects of this talk. And I will say also notably the interactive process, which is pictured here, is not something that the faculty are doing. So the accommodations can only be granted by a disability service office. So if as a student, disability services is who you would want to work with to have your accommodations granted. But it's, I think, a good idea for everyone to kind of understand like the broad strokes of what goes into granting accommodations. So when you're looking at determining reasonable accommodations, there are three big goals. You don't want there to be undue hardship. You want to ensure that there's not fundamental alteration of a curriculum in order to achieve technical standards, and you want to make sure that patient safety is maintained. And I think that those kind of sound really obvious when you are initially talking about them. But for example, like what is undue hardship? So there was a court case, Arigney versus Creighton University in 2012, where the Creighton University denied a $50,000 to $60,000 per year for an accommodation of communication access real-time translation, which is like a form of live captioning for a medical student. And actually the court sided with the medical student, saying that that was not an undue hardship because it was a centralized budget. And so the entire budget of the university was what needed to be taken into consideration, not just the medical school budget. And I also think that at this point, it's probably pretty obvious that not one size fits all. And that's the other reason why like disability specialists need to be involved. Disability services need to be involved in the accommodation process. So somebody who has a visual disability is probably going to have different accommodations than somebody who has a learning disability, than somebody who's deaf, hard of hearing, or somebody has mobility limitations. And even within any of these areas, like there's a huge spectrum of what of severity or how impacted you are, which may also affect the accommodations. Another element that has been really important for all of our clinical faculty to understand is the idea of disclosures and confidentiality. And the decision of whether to disclose a disability or not is really complicated. And it's based upon the interplay of local culture and how to optimize communication and education without stigmatizing or othering or infringing on anyone's individual privacy. And there's a lot of fear around disclosure of a disability. So fear of judgment, bias, and skewed perception of ability. There was a study by Miller and colleagues in 2009, and 2 out of 3 students had not sought support despite experiencing disability-related difficulties in their training, and 12% of students reported feeling discriminated against. So in an ideal world, disclosure of a disability within a culture of support could lead to enhanced communication that allows for like rapid and innovative implementation of accommodations. But at the end of the day, the decision of whether or not to disclose is solely that of the individual with the disability. And that might mean, and this has been challenging for our some of our clinical educators to experience, like that might mean that somebody chooses to miss out on some educational opportunity or tool or innovative way we could do things because they want to avoid bias and judgment that they feel may come along with their disclosure. And that is their legally protected right. Just like somebody who doesn't have a disability can choose to go home after the OR and not read their anesthesia textbook, even though that might improve their learning. Like we're all allowed to make choices about our learning. Sorry, I'm just working. Oh, I got it. I did it. You guys see me learn in real time on Max's computer. And so then when we were talking to some of the leaders of the medical students for disability health and advocacy group, there was a question around disclosures and confidentiality that came up that I would love to spend a little bit of time on. And the question was about sharing of accommodations. So even if a student chooses to disclose to a program at large or has accommodation about their accommodations, the privacy of the educational records are federally protected via the Family Educational Rights and Privacy Act, or FERPA. Just as a quick caveat, residents are ever so slightly different because they're both learners and employees. So this is most accurate of medical students. So said in a different way, accommodations are FERPA protected information, and they should only be shared with folks who have an educational need to know. And what exactly constitutes an educational need to know is going to be really variable depending on what the accommodation is. So for example, in anesthesiology, we don't really administer tests. And so if you had an accommodation that granted you longer test taking time, like that wouldn't really be something that anyone in anesthesiology would need to know because they're not administering any tests. Alternatively, if you had an accommodation where you needed to wear, you and the team within which you were working needed to wear clear masks for like enhanced communication, like then everyone would need to know that because they would need to be able to wear the clear masks. But regardless of this, at most it's the accommodation that would be communicated. It's not personal health information. And then in terms of the way accommodations are shared, I spoke with, or I emailed JT about this ahead of the talk. Michigan is a national leader in this area, particularly in terms of medical student education. So for a lot of places, the onus of the disclosure is on the student, and that is done in order to emphasize confidentiality. So the student is choosing who to disclose to. But you can imagine, how many of you have been in the clinical setting so far? Okay, so like sometimes it's hard to know who everyone's roles are and what role they're going to have in your education. And like if your job was to disclose to every single person that you thought was going to have like a specific role in your education, that would be a big task to take on. And so at Michigan, when students engage in the accommodation process with disability services, there is a conversation about how the communication for disclosure of disabilities will go at that time. And the Disability Services Office has been very proactive in helping to make that communication to like the clerkship so that the students aren't having to focus on that and they're able to focus on learning. And then disability services can help the clinical educators implement the accommodations to the best of their ability. And it's been met with like overwhelming satisfaction. Okay, so we're gonna pause. I'm an anesthesiologist, so I'm wondering how many people here have done an anesthesiology rotation or have had experience or exposure to anesthesiology. Okay, awesome. Does anyone, and this is incredibly low risk, I cannot emphasize this enough, but does anyone want to describe a typical workflow for an anesthesiologist who's got like a healthy adult patient undergoing a general anesthetic? Does anybody have any sense of like what that job entails? Otherwise, I can do it if you guys want. So generally speaking, you're going to come in early in the morning, you're going to set up your operating room. Setting up your operating room involves doing a machine check, drawing up drugs, making sure you have all of the right equipment, depending on what anesthesia you have planned. Let's say we're going to do a general anesthetic with an endotracheal tube. We want to make sure we have all of that stuff. You go to pre-op, you meet the patient, you do a focused history and physical, you talk about your plan, and then it's different at different places. At our institution, the anesthesia team is who pushes the patient back in the stretcher, but at other places, the OR nurses do. It just depends on the workflow. And then you help facilitate either having them move over, or if they can't, helping them do that. You hook them up to their standard monitors so that you can keep them safe. You pre-oxygenate. And then if you're assuming you're going to do a general anesthetic, you push induction drugs. You would bag mask ventilate while you were waiting for the muscle relaxation or paralytic to set up. And then you would go on to do your direct laryngoscopy. And generally by convention, most of us do like our laryngoscopy with our left hand and then use our right hand to put in our endotracheal tube. And then you're with them, keeping them safe and comfortable the whole case, right? So that could be giving meds, giving fluids, decreasing your anesthesia gases, whatever you need to do. And then when the surgery is all done, then you help wake them up, get that breathing tube out or extubate, have them move over to the other bed. And then again, here we're the ones who push our patients to the recovery room. So that's kind of your general workflow. But there's a lot of other things that anesthesiologists do. So they're involved in, putting in neuraxial, like spinals and epidurals, or blocks, using an ultrasound. The middle bottom picture is someone doing an awake fiber optic with a flexible fiber optic camera. If you're worried about a difficult airway. And then a lot of our monitors are associated with tones, right? So like our tone of our pulse ox is telling us how well or not well oxygenated somebody is, and the rate is telling you how quickly their heart is beating. Does anyone want to say anything about like what sorts of strengths they think would be important for an anesthesiologist to have?
Quick decision making.
Yes, quick decision making, if anyone can't hear that.
The ability to multitask.
Ability to multitask, yes, I agree, Dr. Wixton.
Participation of patients, like emergent collapse from like hemodynamic sepsis or
Absolutely.
collapse.
Yeah. So I think those are all amazing answers. And I think sometimes people, when they think about anesthesiology, they really are tying the procedure to anesthesiology. And there certainly are procedural elements of our field. Like it is a procedural field, but there's also a lot of like cognitive elements to our field and communication elements to our field, et cetera. So I think it's just important to talk about that, because I find that a lot of faculty and a lot of students focus a lot on like the IVs and the bag mask ventilation and the intubation. And those are important elements of anesthesiology, but they're not the only elements of anesthesiology. Okay, so these are two cases. They're 100% made up. These are not real people. But we use this to talk. Go ahead.
I was gonna say, sorry,
Yep.
a lot of patients, like when they're really big surgery, like the anesthesia residents, when they talk before you go into it, so like things that placate or like they're stressed and they're like their anguish about the first major surgery is huge in anesthesia. The patient interaction,
I don't know if you guys can hear that in the Zoom land, but basically it was just an answer talking about how important it is for the anesthesiologist to be able to have like excellent bedside rapport and calm people down in times of like great vulnerability and stress. And I would say that that's incredibly important and something that people don't necessarily think of until they've seen that or participated in it. And sometimes people will make jokes about how anesthesiologists like their patients asleep and, you don't need a very good bedside manner, but I think like nothing could be further from the truth. You have a very short amount of time to get these patients to trust you, right? Okay, so these are two students who are totally fictional. We have a third-year medical student named John, who's a wheelchair user. John has a service dog, and John is going to do a 2-week elective rotation in anesthesiology. So he wants to be like a nephrologist when he's done. And he knows that a lot of his patients are going to come to the OR for procedures, and he just wants to have a better understanding of what that is like, so he can be the best nephrologist that he can be. And we also have Mary, who's a second-year medical student. Mary is deaf, hard of hearing. Mary has no idea what she wants to do when she's done with medical school, but she is on a required anesthesiology week during her surgery clerkship. Okay. So just think about those students as we start talking about barriers here. So you can split your barriers into like structural and cultural barriers. And when you think about implementing accommodations in our diverse and heterogeneous clinical learning spaces, you can see that that's one of the biggest structural barriers that we face. So as an example, we only recently realized that our pediatric anesthesiology offices, where all of our lectures are held, were not accessible. So there's literally no way for somebody to enter or exit if they had a mobility issue. And I found that really shocking because of course, like our building is newish and of course it's up to like all codes, but much of those apply to the clinical spaces and not the non-clinical spaces. And it was really, like I said, shocking to realize that no one had considered the possibility of a faculty, staff, resident, or student with a disability when designing these non-clinical spaces. And, you know, we could have theoretically used Zoom in order to create a workaround, but you can imagine that that would be really potentially stigmatizing to somebody who wouldn't be able to attend an in-person lecture that their peers are attending. And more broadly, that structural barrier might accidentally impact the perception of what our culture is like for learners with disability. And even with a very motivated group of individuals and a project manager who was the DEI representative for facilities and a lot of hard work, it still took weeks for us to get push plate access to our office. So even with, you know, everyone trying, implementing accommodations can be really challenging at times. And in addition to needing specific accommodations, we also need the knowledge of our medical educators to consider how to implement these accommodations in our clinical spaces. So we think about how a service dog may be implemented on a radiology rotation. That's probably different than how it might be implemented in anesthesia rotation. And beyond that, we don't just need like our medical educational leaders to be aware of this. We need everyone to be aware, not of individuals' accommodations, but just of the idea of accommodations in general, because the residents and the nurse anesthetists and the OR nurses and the faculty, like that's who you're working with every day in anesthesiology. So it doesn't help if only Matt and I know about these things and we don't communicate it downwind. And it's also can be really vulnerable for clinical educators to kind of think about this and participate in this conversation. And I would say, like, for myself, I felt very naive to like realize that I had never even thought about how someone would get into and out of our offices. Like, and so I know that it is a vulnerable feeling to think about that. And I know that we're in a place that's amazing and really dedicated to being inclusive. So I can only imagine how it may be in other places. But even though new things can be challenging, they can also create really amazing change. And that brings us to the innovation. So a lot of the accommodations, like we talked about, are going to be individualized, and they're going to require creativity and adaptability for everybody in order to create an inclusive and safe environment. For some of the accommodations that we've encountered, the SimLab has been a really helpful place that's like low risk clinically for people to try out different innovative ideas. And so if that's something that a student is interested in, that has been really helpful. But more broadly, what I love about this is that us becoming facile with responding to a learner's individual needs helps all of our learners, right? Like, it doesn't just help people with disabilities, it helps everyone. Oh, that's an amateur video of me opening the door. Anyone's never seen that before. And then other structural barriers can be our technical standards. So if our technical standards are written to reflect organic technical standards versus functional technical standards, that can be a form of a barrier. And this is kind of like beyond the scope of this talk, but you know, in medical school, we think about turning out undifferentiated graduates. And so as you kind of engage in this topic in the literature, you'll see like an argument or a pro-con debate of like, what is having an undifferentiated graduate the ideal circumstance? So opponents would say, like, why would if I'm going to go into psychiatry, like, why would I need to know how to intubate? Like, what would be the point of that, for example? So it's something to consider within medical education. Maintaining optimal health care and wellness support can be another structural barrier. So we probably have all started to experience how difficult health maintenance and wellness is to sustain. And if you imagine that you had a chronic medical condition for which you needed medical care, that would be really challenging. Or if you can imagine that you faced a lifetime of like micro and macro aggressions, probably your wellness is going to be impacted as well, differentially. And then finally, disability services is a very important, vitally important service for students with disability. But the access and expertise of disability specialists in clinical learning environments is really varied, and challenges here can represent another structural barrier. And at U of M, GT Sangslin has been an amazing contact, and she's been really committed with us to help us learn more about how to create inclusive learning spaces. Okay, we're going to come back to John now. Does anyone have any ideas of what might be some accommodations that John might have, or what might be some of the structural barriers that John might encounter in the perioperative space?
Service dog in the operating room.
Yeah, does anybody know what about service dogs in the operating room? So service dogs are like federally protected in like many locations, but not the operating room. So everyone agrees that service dogs don't come in the operating room, but they can go most of the other places. So what do we do with the service dog while a student might be in the operating room? And if you think about somebody who has a service dog, you have to think about, why do they have a service dog? What function is that service dog helping that individual with? And if that service dog is there, like what might be impacted? So if you use a service dog for actually being the like thing that depresses the push plates, having push plates everywhere, if you don't have a service dog, doesn't really help you, right? So then that's like very important to consider. Any other thoughts? So there's lots of different accommodations that a student might have. Again, it's going to really depend upon their particular unique circumstances. But we've kind of talked about the perioperative challenges, and I would say like chief among them are the service dogs, and then the accessibility of the non-clinical spaces, which we already kind of touched on, and the accessibility of the ORs. You know, we've got the ORs you think are like so accessible because you've got people who are going to be pushing a stretcher of a patient. So like, of course, there are push plates everywhere, but a lot of our push plates are in really non-helpful locations. Like at Mott, there's like often a garbage can right in front of the push plate, and it's up really high. And also sometimes the OR staff turns them off because they don't want the doors to open automatically from a sterility perspective. Or if you're in the operating room, you have to hit the push plate, and then you would have to, and then the doors open up into you. So you would have to like immediately move back. I mean, there's just like a lot of, when you start thinking about it and exploring it, it is even things that seems like they would be so accessible, maybe aren't. And then in terms of the technical standards for 2-week rotation in anesthesiology doesn't have like national clerkships, right? So any of your rotations are institutionally managed. And so it's just important for us to make sure that we are writing our educational curriculum and objectives such that it truly reflects what we feel is important for the rotation. So if this is a rotation that like people who aren't going to be anesthesiologists are going to take, then I want to make sure that like I am able to have a diverse group of people who can take the class and be successful, or take the course and be successful. And, you know, like we've already touched on, procedures aren't the only thing in anesthesiology that there is to learn. There's a lot of rich clinical learning to be had. Okay, so now we're gonna do the same thought exercise with Mary. Does anybody, can anybody think of any structural barriers Mary might encounter or accommodations that she might have? Yeah, the mask. So I think the mask barrier is probably the one that really sticks out to most people. You know, Mary might have an ESL interpreter. You know, I learned this year that not all people who are deaf or hard of hearing sign. So this is actually variable. Like if they sign, then this might be an accommodation, but if not, it may not be. Caption services need to be 99% accurate. Otherwise, they're not actually achieving access equal to hearing peers. And that can be quite difficult. The clear masks we've talked about, ability to meet with faculty to clarify, Roger device, which is like a wireless or a Bluetooth amplifier, and then like other amplified equipment, like a stethoscope. And so if you think about the operating room, can you think of what challenges we might encounter in the OR? A monitor, yeah. I mean, we get a lot of information from our monitor. And beyond that, like let's say you had mild hearing impairment. You might be able to hear the monitor just fine in a perfect setting, but how quiet is it in our operating rooms? Like there is music playing.
People talk quietly.
People are talking so loud. There are like noise pollution studies that like it doesn't even meet OSHA like safety standards in the operating room. It's so loud and everyone just talks over one another to try to like, I don't know, get around the problem. So like a really noisy place that would be with a lot of like parallel conversations going on, that can be really difficult. And then if you were using clear masks, some of the ergonomics of our setup, like you would have to be looking at someone in order for that clear mask to be super helpful. And that's not always going to be the case. Okay, Matt, are you still there? Okay,
Oh, yeah.
we're gonna.
I just want to be distracting. My face
We're
is
gonna.
distracting sometimes.
We're gonna move to the next slide, and then we're gonna try to get it so that your like face is showing up in the screen in this room. So give us 1 second, okay?
Fantastic.
Okay.
Did it work?
Give us a second. Yeah. There you go.
Like it there?
Yeah.
Should make him bigger.
I leave him this size for
All right.
now. Is that okay with everybody? If he's this size? Okay, you can go.
I'm good to go.
Yeah.
All right. Well, thank you, Dr. Naziosov, and thanks everyone for being here. This is just really, really exciting to talk about these issues. So we've talked about a lot of the like physical and structural barriers that exist.
Oh, sorry, Matt.
That's okay. Am I doing something funny? You're like smiling at my face. Am I doing it wrong?
No,
Very good.
we're just trying to. Max is like my tech guru right
Guru.
now.
Sorry,
Okay.
it's my fault.
No, we're good. So now I
All
want
right.
to talk about some of the cultural barriers. And first, I want to start by talking about like stereotypes and stigma. We all have stereotypes, right? We all have bias. I think that just needs to be kind of a ground rule. I know that I do. I get paid to think about it and talk about it and try to decrease it. And like I still have stereotypes. And so I think it's important that you spend some time thinking about what are your biases? What are your stereotypes that you have? And how do they affect you? How do they influence how you're working with others, how you're an educator, how you're a physician, etc. And then what is stigma? Stigma is really the outward expression of what stereotypes are. It's assuming that someone with a particular disability is unable to be successful doing this or doing that. Or really believing that because they have a disability, they're precluded from being really good at a task. There's a AAMC report that's really this, it's the seminal paper, I would argue, around disability and medical education. And there's a quote that's really moving from it. And it says, there's an attitude towards disabilities, and there's a stigma. Historically, there's been a stigma of you're not normal, you're not complete, you're not whole. You've got something against you, basically. It's looked on as a negative, as if you're broken. When trying to attain a certain goal and having that little fear in the back of your head saying, oh, but they're going to find out about this and it's going to cause some issues. They may not overtly say, we don't want you. They may, in a more subtle tone, say, not the right candidate, kind of thing. To me, it's like heartbreaking to read, but that is stigma, right? That is the outward expression of all these thoughts and stereotypes that you may have just never addressed. And so it's important to understand what those are and try to start dealing with them. Another barrier is the medical versus social model of disability. We're clinicians, right? We like to medicalize literally everything. And that's what the medical model of disability says. It focuses on the person with a disability as a problem. So we want to diagnose, we want to run tests, we want to treat, we want to reevaluate our treatment and go down that model. So we think about the medical problems or what they're not able to do and try to fix that. However, the social model of disability really turns that on its head, and it's saying it's not the person or their disability that's the issue. It's a society, it's structural barriers we've created that are the issue. And then the focus is on dismantling those barriers instead of just trying to, quote, fix the person. So those are terms you may hear in the literature, and I think it's important to understand them. And I'll admit it's really natural, I think, as clinicians to just try to fix the problem. We really easily fall into that medical model of disability. And then the impact of faculty attitudes and peer attitudes really can't be overstressed. We've talked about how low disclosure rates are. They're slightly higher to peers than they are to faculty, but they're both really abysmally low. And the reason for that is not wanting to feel like people are looking at you differently, like, oh, you're getting something extra to get ahead, and why do you deserve that and I don't? So as peers and as future faculty, we can really lead in that space to create an open and inclusive environment with people with all levels of ability are really welcomed and celebrated. And that's where equity always comes in, right? How can you help them be successful in what they need? What accommodations are necessary? How can you ensure those are being utilized? But I think it's incumbent upon all of us, regardless of our ability level, to kind of enter into that space, because it can't just be the people with the disability who have to continually be advocating for themselves. It takes all of us. So data has shown that the ability to disclose to peers and to faculty really improves well-being. It improves kind of utilizing accommodations that are mandated. So those are some barriers that certainly exist. Other cultural barriers is that words actually really matter. And so you can see on the left some phrases to avoid and how you can use them instead. And in doing this talk, I know Becca and I've changed my vocabulary from even 6 months ago, trying to be conscious instead of saying wheelchair bound, saying someone who uses a wheelchair or wheelchair user. Those, what seem like little changes actually can have outsized influence and impact. It's inclusive speaking, and it's really making sure that you're not perpetuating stereotypes and stigma in how you talk. So I just invite you for a moment, just look at some of these phrases and think about how do you speak, not just about your peers or other people you work with, but patients as well. I think it's hard for me. I still see where I fall short here, and so but that's part of the process. So this is from a Meeks paper in 2018. How do you start to dismantle these cultural barriers? First, educate yourself. You all are here tonight. This is an hour conversation, and obviously you have an interest in this, or you wouldn't have shown up tonight. But just continue to educate yourself, and then educate those around you. Develop an awareness by read the literature. Ask about what the accommodation programs are at your institution or in your residency program or a GME program you may join. And that's understanding what's available, both to you and also to people around you. Really have a deep understanding. I know we've been singing JT's praises, but she's been an amazing resource for understanding, what exists at the medical school level. Use syllabus statements, be really intentional about what stated goals are. It's easy to assume, that everyone will understand what the point of a rotation is or an experience, but be really thoughtful in what your statements are there. Plan for students with disabilities, and be creative, be proactive around that. Innovate. I think, you'll see it's bolded and underlined and italicized, which is Dr. Naziostov's way of saying this is really important. But this is the key thing. Be innovative, and that's not And innovation is not just like, oh, here, I'm going to do this thing for you. It's how can we work together? We have a resident right now who has a physical disability, and we get to innovate with them on a regular basis. I don't know how to do things the way that they're going to need to do them. I know how I do it, and I can say, this is what I do. And then I help them innovate with how they approach it. So be innovative. Include disability in your teaching. Be really intentional about, inclusive language, inclusive examples. Promote a social model of disability. Fight against that medicalization of we can just diagnose and fix the problem. No, think about what the barriers are that you can decrease. And then research, right? It needs to be part of the research agenda. So has anyone ever heard of Dr. Winnie? If you're at our grand rounds, you heard it. A couple of hands are up.
Nobody here is raising their hand.
Really? Max, you should be raising your hand right now.
I don't remember.
So Dr. Winnie is an anesthesiologist, and he just has a remarkable story. So he's considered one of kind of the founders of regional anesthesia. He has seminal publications in the field, everything from the brachial plexus to the 3-in-1 block. He did formal studies of epidural and intrathecal steroids for pain relief. He was the first president of ASRA, which is the American Society of Regional Anesthesiologists. He was chair of anesthesiology at the University of Illinois, president of the Illinois Society of Anesthesiologists, and was like amazing, like kind of did it all from an academic career. He passed away about 8 years ago now. But before he did all of these things, he was a resident at Cook County Hospital, a really famous hospital in Chicago. He contracted polio, rapidly progressed to paralysis, respiratory failure. He was ventilated for over a month and then had months and months and months of rehab after that. He ultimately had a motor level of paralysis at T7. After he went through this really prolonged illness, he returned to medicine and did a residency in anesthesiology. As a physician learner and a wheelchair user in 1960, he innovated, and that's why innovation was bolded and italicized. He innovated all these different ways. So like surgical tables that had a hole in them that allowed him to wheel his chair underneath to do procedures. He invented a technique to place a spinal patient, to put a spinal block in, a subarachnoid block in a recumbent patient. And he also invented a periscope so he could look over the drapes at what was going on in the surgical field. So this isn't just like theoretical, maybe this person could go into internal medicine. Like this was 60 years ago now, someone who had a physical disability and found, the practice of anesthesiology is directly different because of work that he did, in the 60s and beyond. This is a really interesting case report from MGH. So it's from 2016. It was an anesthesiology resident who had, a hidden disability, who had ADHD. They've been diagnosed at 10 years old. And despite difficulties with processing speed, self-motivation, time management, organization, they ultimately received psychopharmacologic therapy and academic accommodations and was accepted into medical school. However, after that, once he was in medical school, he never actually requested subsequent accommodations because he feared being stigmatized. So he excelled academically. He worked really, 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 really hard and was ultimately matched at a top-tier anesthesiology program. It's not a secret. He matched at Massachusetts General, a really premier institution. However, once he was in residency, things started to go. He started to struggle. He had excessive perfectionistic tendencies, recurrent lateness, time management issues, and task prioritization difficulties, led to structured remediation and then a leave of absence. When he was on his leave, he began a structured program of cognitive behavioral therapy. And he made the decision to disclose his ADHD diagnosis to his program director and asked for educational accommodations, within the structure of the residency. He received those accommodations, as was his right, and worked really closely with this program. He came back ultimately, graduated successfully, went into a highly competitive fellowship, and is now an academic anesthesiologist. And unsurprisingly, he's one of the best educators in the entire department. So this is another example of how important accommodations are. And I think a sad example of where the fear of stigmatization led this student and this physician to struggle for a lot of years, because they didn't feel comfortable sharing what they needed to be successful. So we want to end by saying, like, you belong in the room. All of you, all of us belong in the room. An invited commentary by Schwartz and Zekulik in 2019 talked about their personal experiences with obstacles faced in medical education as individuals with disabilities. An excerpt from the publication, whose title was the inspiration for this talk, says, "Nothing disrupts the streamlined movements of bedside rounding, like the threat of my wheelchair running over someone's foot. A few weeks into my clinical rotations, while still learning to maneuver on the floors, I found myself apologizing repeatedly as our team took their places in a particularly crowded room. A classmate's comment has remained with me. There's no need to say you're sorry. You belong in this room too." And that's what we're here for. We want to create, certainly a department of anesthesiology in a field where everyone knows that they belong in this room. And as medical educators, that is our goal too. Whether you all become anesthesiologists or not, we want you to know you belong in the room in which you find yourself. So I'll end there. The last thing here, you'll see our references, and also a really great resource. You may or may not have seen this, the Docs with Disabilities Initiative, which is Dr. Meeks is one of the founding directors of that initiative. Just has a lot of really great resources that you can check out. So with that, I'll end, and thank you so much for having us here tonight to talk about this important issue.
You're almost out of power. I'm gonna stop the share here. Does
Yeah, and we'll
anybody?
wait, any questions?
Yeah, does anybody have any questions either here or elsewhere? Also, this computer might run out of battery imminently.
Have you noticed accommodations change in anesthesia, like for med students, for residents over the last couple of years as you've really dug into this work more, or like, I don't know, whenever the work kind of began, have you noticed things change in the department?
So I would say that the cohort we have currently of people entering into the clinical space with the medical students is one of the earlier cohorts where the disclosures are being facilitated by disability services. And so, when it was on the students to disclose, I wasn't hearing very many disclosures of disability. And so I don't know if that represents a positive change in terms of like people feeling safe to disclose, or just that conversation is being facilitated. But it definitely seems to be an increase. And then we also now, this isn't new, but now anesthesiology is required, whereas before it was just an elective. And so you could imagine that potentially people were choosing to not do an elective in anesthesiology if they didn't perceive that it would be a rotation that would achieve their educational goals, or that maybe would be challenging from other perspectives. I don't know, Matt, do you have anything to add?
Yeah, I think all of that's spot on. I also think that people in the department are just learning a new language. around disabilities and accommodations. I think if you asked them a year ago, what's an accommodation, the average person may not have a very good answer. And I think that kind of targeted education has improved that. And I think people are in general becoming more comfortable, like being uncomfortable or saying like, I don't know the answer. I don't know exactly what to do in this situation. Can you help me understand? I think that, and I think that's been a big change. I think for a long time, people would fear saying the wrong thing or fear like bringing it up, or they just didn't know what to do. And now I think people are like, I want to help you learn the way that's going to be best for you. So there's still obviously lots of work to be done. I think that's true in probably all of medical education, but I think it's improving.
What about the OR and people being used for it? The VIS monitor, the guys for putting this monitor, for it being like debatably useful for having anesthesia, it's like not using some of the solutions that others. Just curious, Michigan uses it like for patients for IV.
So that's a good question. We don't generally use the BIS at Michigan. We use, oh my God, I'm like totally blanking.
Deadline.
Thank you,
Sedline.
Sedline. Thank you. So we use the Sedline more for our TIVAs, our total IV anesthetics. That's what we tend to use more here. So it's like a similar concept, but it's not the BIS. Yeah. Any other questions?
Do you see initiatives like this at other specialties and health institutions? And I guess, do you foresee this becoming kind of a standardized structure and process for all specialties?
I mean, I guess I'm not as involved in what the other rotations are doing, so I don't know that I can like expertly speak to what they are or are not doing. I think JT might still be on, so she might be able to offer some insight into that. But I think our hope is within the field of anesthesiology to make this a conversation that we don't see happening to the degree that we would like it to. Michigan is like a leader in this area. And so I think that, you know, Matt and I feel strongly that within anesthesiology, it's an opportunity to kind of share like what our experience is here. And like I said, get people talking about that within our field. I see JT's camera just came on, so we're going to try to put you so everybody can see you one moment.
Okay.
Oh, way to go. Okay, here you are.
Thank you. I appreciate coming to listen. For me, this is kind of formative assessment of hearing how things that we're trying to support show up in the atmosphere. So I appreciate you letting me come. I'm hard of hearing and have accommodations myself, for those that don't know. And in terms of like what's happening in different clerkships, so Matt and Becca did a really nice job, and I really appreciate capturing where we're trying to head around staff, faculty education, and systemic shift, because we can focus on the individual a lot, and that is we tend to focus on students and what can we do with and to students, and what's needed when you want to have broad implementation is this like systemic shift and those things that you guys were talking around education. So that is a new process this year, communication with the clerkships in conjunction with the students. I just want to be clear, nobody's telling anybody anything that we haven't talked to the students first. So we have that conversation about how do you want the communication to go, and overwhelmingly we're hearing like, yes, please help us put the information out. If somebody said, no, I don't want you to tell anybody, I'm not even sure I want to tell folks, we can keep students on what we call on consult, or maybe we do an evaluation, we figure out your accommodations, and we just hold on to them until you kind of find your way through it. But overwhelmingly, that education's been really important. We've been really deliberate about meeting with clerkship directors as a whole and individually. We're doing advanced planning conversations for anyone who has accommodations more than the time testing Becca mentioned. So it should be that we're seeing an improvement across the clerkships. I think I caught the word standardized. The captions didn't totally pick up the question, but yes, we're trying to do this broadly across the clerkships. That being said, one of the things I love that Matt and Becca emulated and talked about was like getting comfortable learning something new. And folks are in different places. Folks have different experiences having a disability, knowing somebody with a disability. They might be, quicker to jump in and be champions. And that's the other reason I'm here. I'm always keeping an eye on like where are early adopters and champions so we can bring them out to speak to their peers. I hope that answered the question.
Yeah, it did. We're frozen over here, but we can hear everything and see you guys. So
Awesome.
does anybody have any other questions?
Just a question, so I'm M1, and I haven't had any presentations yet, but I just wanted to hear you guys speak a little bit about caring for patients with disabilities, and basically if there are any particular accommodations, in particular within anesthesia that you guys have to deal with, depending on like patients' needs.
Yeah. So the question was about caring for patients with disabilities and any specific like accommodations or challenges that we are running into, or like innovations for those challenges that we're dealing with in anesthesiology. Is that a good summary of it? Okay. So I'm going to give my answer like related to peds anesthesia because that's what I do, and I can let Matt adjust it for adults if he would like. But so Michigan is like, again, a leader in this area. They're starting to be under gender. There's a disability tab that is showing up in my chart as well. That is pushed to the patient portal that patients can fill out, and they can identify if they have a disability, any accommodations or alterations to like the clinical environment that might be helpful for them. So that is a tab that's like starting to get used. I haven't seen it used as much in peds as maybe it is in adults. I don't know if Matt can speak to that, but in peds, we're fairly lucky in that usually a caregiver, like often a parent, is with us. And so they're able to be an advocate and potentially, depending on like their health literacy, advocate for specific things in the peds perioperative space. And then we also within peds for patients with autism, which is something I would say that we run into fairly frequently. We have a process whereby when the patients are called preoperatively, if autism is a diagnosis or the parent mentions that they have autism, there's kind of an enhanced questionnaire that gets administered about what are some of the things that they would find important or valuable, or conversely, what are things that could be really negative in that space. And then we do what we can to try to accommodate that, like a private room, trying to get everybody on board. So only, not the whole care team is like walking in, which can be a huge amount of people. Making sure that you're choosing the language that works for that patient. So I would say that those are the areas where I currently see the most like work on within the peds anesthesia realm. I don't know, Matt, can you think of any to add for the adult realm?
Yeah, I think that we're not as advanced as the peds world is yet, to be completely honest. I know that we just switched to my chart anesthesia today, and I know that there's a tab that's an accommodations tab, and so that's going to start being populated more, and I think that that's going to be helpful. I think a kind of obvious example would be, if someone utilizes an interpreter, that's not an accommodation in the sense of not speaking English as a disability, but I think that there have been times when anesthesiologists have been like, oh, I'll just have a family member like interpret or something like that. And I think there's really been a push to like, no, that's not the right thing to do. The right thing to do is utilize an interpreter who is trained in medical, interpretation. A family member is not the right substitute. So I think that, that's an example of where I think there's been big improvements even in the past couple of years, but there's a lot of work to be done still.
We're still here, just
Now
blacked out now, but does anybody have any other questions?
It's degrading quickly, I see.
I know, it's like your time is up.
What will be next?
I guess one last question.
Yeah.
Are there any innovations in the works right now or that you're excited about? Anesthesiology or previous?
The question was about if there are any innovations like in the works right now, either within anesthesiology or anesthesiology that we're excited about. Are you asking like specifically within disability or just like in the whole field?
Within disability.
Okay, I was like, it's a big question, Anna. I would say like not necessarily an innovation, but like I said, Matt and I are committed to trying to get this conversation started within the field in general. And I think that that's something that is lacking, and I think would be really exciting if we could get that going. So I think that is awesome. I will say that I really enjoy the sim space, like I alluded to earlier. I think has been really helpful because I just, I am not an expert on what somebody with a different like mobility limitation has. And so I can say, the way that it works for me or the way that I do it or like what our goals are or whatever. But I think that being in that the simulation space has been a really helpful opportunity for like that dialogue to happen in a low pressure way, and people to kind of come up with what is the right way of doing it for them. So I think those for me are and I see JT has put in a comment. And just highlighting also that the Sim Center has been useful for them as well for planning for accommodations. So yeah, I totally agree. I
And
don't
I
know,
think
Matt, are there any
also-
other things?
I would just say, I think that there are going to continue to be more innovations around like things that, like tools that we use, like we intubate utilizing our left hand because the blade was designed that way, but that's not to say you couldn't do it using your right hand if the blade were designed opposite. And actually there is now a right-handed laryngoscope that exists. And so I think you're going to continue to see that. I think that the advent of ultrasound is also going to be just innovative. And I think how we can utilize ultrasound to be extensions of ourselves is going to be really helpful in anesthesia. So things that, someone may palpate like an arterial line, you can use an ultrasound and you can see it and place an arterial line. So I think you'll start to see those innovations happen more and more.
Awesome. Any other questions? Thank you. Oh, sorry, go ahead.
I'm going to log off, Becca.
Yeah. Thank you, Matt.
Thanks, everyone. Bye.
Thank you. Hypotension also common anesthesia for patients like in both areas. So I guess like having conditions like disorders that usually cause like low blood pressure, like a special method of like counting those patients for anesthesia. That's low blood pressure so complication.
Yeah, I mean, I think so. A huge part of our training is getting to understand all of those different medical conditions, and or like identifying resources for like a deeper dive when you have a patient coming. So a thorough preoperative like history and physical are super important in order to identify those patients who are at risk for hypotension. And I would say that, you've touched on like some endocrine disorders can be associated with it, but hypotension is unfortunately like an omnipresent fact in anesthesia because it's like most of our meds are going to drop your systemic vascular resistance or your cardiac output. And so it is something that we unfortunately see really commonly. And our goal is always to try to come up with an anesthetic plan that prevents that. But if we're not able to do that, then we would respond to it. But yeah, I think that's definitely an important thing for us to be thinking about within anesthesiology. You guys have any other questions? Feel free to email me like anytime, any questions. I'm always available. It can be about this, it can be about anesthesia in general. Thank you very much for letting us come in and chat about this. It was really lovely.